Hello, everyone, and welcome to this new COVID series from the Institute for Global Health Sciences. My name is Jaime Sepulveda, and I will be moderating this session. But before we get started, I would like to ask all of you to join me in a moment of silence, or even better, to put a knee down and raise your fist as a sign of protest for all of the Black people killed by police, for the structural racism against people of color in this country. And I would also like to say for the lack of moral leadership from the White House and its incitement of violence, which cannot be condoned. So we'll take a couple of minutes to close our eyes, moment of silence, and I will kneel down. Thank you, everyone. So today, we have three great panelists addressing a topic that I don't think has been very well covered so far, which is how COVID-19 is impacting maternal and reproductive health here in this country and around the world. So the three panelists we have today are Dr. Dilys Walker, who's a professor in the Department of OBGYN, and also the director of the Maternal Neonatal Child Health Cooperative at the Institute for Global Health Sciences. We have Dr. Patience Afulani, who is assistant professor at the Department of Epidemiology and also faculty member at the Institute for Global Health Sciences. And we also have Nadia Diamond-Smith, who is also an assistant professor in the Department of Epidemiology and a member of the IGHS faculty. So without further ado, let me pass the mic to Dr. Dilys Walker. Dilys, you have the floor.
Great, thanks very much, Jaime. I appreciate it. Hopefully you can hear me, and I'm getting up my slides as we speak. Let me know when you can see them. Is that up there? Okay, I think we should be ready to go. First of all, let me thank all of you who are joining live to this presentation. And if you're joining non-live, but listening to the recording, I hope it's because you're out being part of the vigil that UCSF is sponsoring and playing a small role in our world today. If I'm like any of you, I can't help but feel very strangely how different our world is today than a week ago, at the same time how unchanged it is and what that brings home. So we'll take the next time to talk about another sector of the population that is often subject to extreme disparities and the consequences of that. And we're going to talk a little bit about navigating COVID-19 and how it has disrupted not only RMNCH research that all of us are involved in, but also the services on the ground. As Jaime said, I'm joined by Patience and Nadia, and very briefly, let me give you an overview of what the three of us are going to talk about. So I'm going to provide a bit of an introduction about just what are the direct and indirect effects of COVID on RMNCH, reproductive, maternal, newborn, adolescent, child health. Then I'm going to pass it to Patience and Nadia, who are going to talk about some very relevant research that they have individually been able to conduct in this new world of COVID-19 and some of the very interesting and important insights that they are gleaning from that work. And then hopefully we're going to have quite a bit of time to discuss not only what each of us present in our very brief presentations, but some of the things that we have been talking among ourselves and topic areas that certainly deserve a lot more discussion are around what are some of the disruptions each of us are experiencing in our research, our implementation work globally in light of COVID-19, and how do we really do the right things at the right time, because certainly there needs to be a lot of flexibility and changes in our research programs. We also could talk a little bit about social media, because both Nadia and Patience are going to be leveraging social media to obtain data. And one other topic that is also sort of near and dear to all of our hearts is this issue of how might COVID-19 be affecting respectful maternity care. So first, very briefly, let's just talk about what we know about the direct impact of COVID-19 during pregnancy. So women who are pregnant and get COVID-19, basically the acute respiratory distress syndrome develops in up to 30% of hospitalized patients. We know very little in sort of the overriding message of this brief slide is that we know very little. What we do know is that the presentation tends to be very similar to that in adults. There has been some reports of increased fetal distress, preterm delivery, and some increased rates of cesarean delivery. Now, it's unclear whether those increased rates of cesarean delivery are because they are promoting early elective delivery in some situations. And so far, there has been no clear evidence of in utero transmission, and WHO and others are recommending breastfeeding on the global scale. Although I know here in the Bay Area, I have heard many cases of mothers being separated from their infants who have tested positive for COVID, and there's all sorts of different moving guidelines around this. So let's talk a little bit more about what are the indirect impacts. And there's a lot that was learned from this initially through the Ebola outbreak. And by this, I mean, what does the fact that there is a pandemic going on mean to services like family planning, abortion, antenatal care, delivery care, newborn care, vaccination, nutrition? These are all areas in which secondary impacts, indirect impacts because of transitions in service, delivery, access, and all sorts of things that we'll talk briefly about. The most that we have learned about this are some modeling work that came out middle of last month that gave specific estimates as to what might the indirect effects be on maternal and child mortality in low and middle income countries. This used the LIST modeling tool in order to do these calculations to find out what would some of the decreases in access and use of a total of 77 interventions, so 77 interventions across those essential services, what would changes, reductions in coverage due to actual lives saved or lives lost. And they modeled 3 different scenarios, from a least severe to scenario 2, which was moderate, scenario 3, which was much more extreme. And what they found in the least severe scenario was it would result in an additional 250,000 child deaths, an additional 12,000 maternal deaths, due simply to decreased access to those essential services and 77 interventions. And then the most severe scenario, which, as you can see, even more extremes, which over 1 million additional child deaths and 56,000 additional maternal deaths. Now remember, the global number of maternal deaths currently is estimated about 280,000. So this is up to, a significant increase, up to about a 40% increase in maternal deaths. And why is this? It's felt that the reduced coverage of things as simple as administration of uterotonics or medications to stop postpartum hemorrhage, antibiotics to treat infection, anticonvulsants to treat preeclampsia, eclampsia, and just clean birth environments account for 60% of those additional maternal deaths. The increases in wasting due to the decreased access to food supply, food, and poorer nutrition result in about 20% of the additional child deaths. And the reduced coverage of antibiotics for pneumonia and sepsis and oral rehydration will account for about 41% of those additional child deaths. So when you think about these conditions, it seems tragic that advances will be lost. What about some of these direct actions lead to indirect impacts of COVID-19? So let's look at antenatal care. We're going to look very briefly antenatal care and intrapartum care. And currently, WHO recommends 8 contacts during pregnancy. They should begin before 14 weeks, and there should be a postnatal visit at 1 week. In light of COVID, systems around the globe are delaying the gestational age of first visit. They're reducing it to 1 every 3 months, and the postpartum visit is often being delayed to 3 months, which in fact is no longer a postpartum visit. So why is this? The challenges that systems are confronting are, number 1, congestion. How do you decrease the the impact of crowded people together and the risk for COVID. Antenatal care tends to be delivered all visit the same day, morning only. There's not enough PPE. There's gaps in training. Providers don't know what to do when they're confronted with a potentially COVID positive patient, nor do they know how to decrease the risk of transmission. And we all know that there is both provider and client fear across the globe about caring for patients and about going to a facility where they may get infected. So I tend to be a bit of an optimist in this and thinking, the issues around poor antenatal care are things that are potentials for system changes that may lead to sustainable changes. So can antenatal care be reorganized to be offered in a different manner? Can women have a selective schedule based on an actual risk assessment rather than everybody needing the 8 visits? Can some of this be done in the home? And can some of these be done as virtual visits? So potentially, is there a net positive at the end of this journey? In terms of intrapartum care, WHO recommends facility delivery and skilled birth attendants. Again, many providers in maternal wards have been redeployed to COVID wards or to testing services. I've heard in Tanzania an entire maternal child facility has been transformed to a COVID facility. And where does that leave the mothers and their babies who are in labor and delivering? Providers, midwives are afraid to go to work. In Nigeria, we've heard of midwives staying at home because a midwife was infected with COVID, and now all midwives in that region are being targeted. And as I said before, women are afraid to come to facilities because that's where they think they might get infected. So what are similarly, the challenges and the opportunities for intrapartum care? Congested, inadequate PPE, respectful maternity care. Just briefly, there's been a lot of effort to get birth companions at the side of women during labor and delivery. And certainly because of the risk of transmission, that clock is being dialed back in a big way. There's problems with supply chain for the critical commodities, training gaps, provider-client clear. So is there a world in which there's selective home delivery with the appropriate backup that might be the right thing and might be a more person-centered approach to birthing? Is there a way to change the way the facilities are organized and designed such that in the end, women are giving birth in less congested areas if they have to be found? And can we just get soap and water into these facilities? Will this be enough motivation to get the 16% of facilities who don't have soap and water because of this motivation? So let me just leave you with this. And this came from a commentary that was associated with that publication that struck me particularly, that the fear of the unknown and extensive misinformation are creating a breeding ground that may reverse the progress achieved in basic health indicators such as maternal and child mortality during the past 20 years in LMICs. And with that thought, I'm going to pass pass the screen on to Patience Afulani to share some of the exciting work she's done in just the past couple of months. Patience?
Thank you, Dilys. Okay, can you see my screen? So thanks, Dilys, for the introduction. So today I'm going to be presenting some work we launched in Ghana a couple of weeks ago on healthcare workers and preparedness to respond to this pandemic and associated stress and burnout. So although the data I'll be presenting is not purely from maternal and child health workers, it includes a large proportion of RMNCH providers, and the findings are relevant, if not even more relevant, for RMNCH. So let me start by acknowledging my collaborators. So this work has been a very collaborative project involving people who volunteered their time because the project was not funded initially. So the UCSF team includes Dr. Nito in the School of Nursing, Equia with CAPS, and Mona. And then we have colleagues from the Ghana Health Service, including the Director of Policy Planning, Monitoring and Evaluation, colleagues from University of Ghana also. Everyone contributed to questions and in the dissemination of the survey, which I'll describe next. So some brief background on COVID-19 in Ghana. So Ghana recorded its first case on, actually first two cases on March 13th. Since then, there has been an exponential increase in the number of cases. So this slide is from the Ghana Health Service website where you can get updates on the COVID situation daily. And as of yesterday, there were over 8,000 confirmed cases with 36 deaths. Ghana instituted a lockdown on from March 30th to April 20th, about 21 days, and the lockdown has been lifted. So even though cases continue to increase in the country. So the objective of this study was to examine healthcare workers' perceived preparedness to respond to the pandemic, as well as their stress and burnout. And the motivation for this was basically based on initial initial things we heard on social media on providers' lack of preparedness, but there was no study documenting this actually. And then also I had become very interested in stress and burnout as a key driver of disrespect and abuse of women during childbirth, and had started looking into this issue in Kenya. And so this was an opportunity to look at sort of additional sources of stress in this pandemic that could contribute to higher stress and burnout and potentially increasing disrespect and abuse of women during childbirth. And the hypothesis going into this was that perceived lack of preparedness will increase stress and burnout, which in turn would contribute to more disrespect and abuse of women during childbirth in health facilities. So we focused on all healthcare workers in Ghana, and this was partly because of the approach we were using to recruit. So it wasn't a targeted approach reaching out specific healthcare providers. So the survey questions were developed in such a way that anyone working in a healthcare setting could respond to their questions. We proposed an explanatory sequential mixed methods design where the plan is to collect survey data and then follow up with qualitative in-depth interviews to be able to explain the survey findings in more depth. We developed a Qualtrics survey with about 100 questions and launched it on April 17th. So there was a quick turnaround from the idea to the execution. So I first reached out to colleagues in Ghana about this project on April 2nd, and we launched the survey on April 17th. The turnaround for IRB was also very quick, within 3 days. And as of Sunday, May 31st, we had about 650 responses. So just some quick preliminary results from this. So as I mentioned, a large proportion of the providers who responded work in maternity and RMNCH related units. So about 30%, higher if you consider those who work in the pediatric unit and also those who work in outpatient and outpatient units that might include care for women and children. And we have a good distribution of various groups, although most of the respondents are in nursing related professions, including midwives and physician assistants. 18% are doctors, and we have the other group of providers, mostly allied health professionals, making up about 18% of the sample. Most of the providers also work in public health facilities. That's about 62%. We have 23% working in the teaching hospitals in Ghana. There are 3 teaching hospitals in Ghana, and about 15% from private facilities. There's a pretty good distribution across age categories, gender, years of service, and also across all the regions of Ghana. So we developed 15 completely new questions on COVID-19 preparedness. And these questions were developed basically by the team and soliciting input from various healthcare providers, asking what questions they thought were relevant to understand providers' perceived preparedness to respond to COVID-19. And we ended up with 15 questions, including questions on providers' perceived preparedness of themselves. So questions like, how prepared are you as a healthcare provider to assess and triage patients, accurately put on PPE, implement standard contact procedures. Also questions on how mentally prepared are you to attend to COVID-19 patients. In addition, we have questions on their perceptions of how prepared their facilities are. So questions like how prepared your facility is to diagnose COVID-19, manage it, and prevent spread of the infection to patients and healthcare providers if you had an infected patient. And these questions are on a 4-point response scale, going from 0, not at all prepared, to 3, very prepared. And we had options for those who said they did not understand the question, or for whom the question was not applicable to. And so far, we've developed a scale based on this. It has very good psychometric analysis with an alpha of 0.91. And so based on the summative score from the 15 questions, and then generating cutoffs based on the initial scale, we have only 27% of the providers feel prepared to respond to this pandemic, with most of them, about 58%, feeling only a little prepared. 16% feel they are not prepared at all for this situation. The questions on stress were from a validated psychosocial measure of stress, the Cohen perceived stress scale, which has 10 questions, with questions like, in the past month, how often have you felt unable to control important things in your life, felt nervous, stressed, and several other questions. And these questions we combine to create a stress score, which also based on cutoffs recommended by the developer. We find that 31% of the providers have low stress, 65% have moderate stress, and 4% have high stress. And then what the final main outcome was the burnout measure. This is also based on a validated psychosocial measure of burnout, which asks people to report in the past 30 work days, how often they felt things like, I feel physically drained, my batteries are dead, I have difficulty concentrating, I feel I'm not capable of investing emotionally in co-workers and patients. And this has responses from 7 to 1. And we are able to combine this to create burnout scores, and also based on the developers cutoff, we come up with these categories. And so with this population, 33% would have no burnout. We have 47% having low burnout, and 21% having high burnout in this sample. And then just some examples from other variables. We have questions on communication. We have almost half of respondents feeling like communication from management and their supervisors is very poor. Also almost half reporting not feeling appreciated for their work. About half again reports fearful of contracting COVID-19. And almost 80% of respondents do not feel confident that if they were to get infected, they'll be adequately cared for in their workplace. Other examples on family support, I wanted to highlight these questions on satisfaction. So on satisfaction before COVID crisis, we had about 15% reporting not feeling satisfied with their jobs. And currently we have about 45% feeling either very dissatisfied or dissatisfied with their job. We have questions also on availability of PPEs, training, having wards for isolation, protocols for management. I thought for this presentation, what was relevant is the fact that 45% report that their facilities have no protocols for managing pregnant women and newborns with suspected or confirmed COVID-19. Another almost 29% don't know if they have any such protocols. And so far, there are very small differences between RMCH providers compared to other providers. So 21% of RMCH providers feel prepared compared to 30% of other providers. Also, we have 62% of RMCH providers having high to moderate stress compared to 51% of other providers. But burnout levels are similar for RMCH providers and other providers. We have very little differences by provider type. In general, most providers have similar levels of preparedness ranging from 25% for doctors to 29% for other providers. But doctors seem to have higher burnout levels. So burnout levels are 25% among doctors compared to 21% for nurses and 15% for other group of healthcare providers. So we're still doing the analysis on this. I just wanted to share a summary of some of the predictors. So far, we find that the factors associated with preparedness are having been trained on COVID-19, having clear protocols in their facilities, having adequate PPEs, having an isolation ward, and perceiving communication in your facility and from management to be good. The training effect is partially mediated by perceived knowledge and skills to respond to COVID-19. Furthermore, lower perceived preparedness is associated with increasing stress and burnout. Also, perceived appreciation at work and family support are associated with lower stress and burnout. The interesting thing we find here is that the association between perceived preparedness and both stress and burnout are partially mediated by fear of infection and job dissatisfaction, which are both associated with increasing stress and burnout. So I wanted to end by circling back to this op-ed that Nadia and I wrote in April, calling for attention to respectful and responsive maternity care during this crisis. And we know that high stress and burnout leads to poor quality care with implications for both safety, but also person-centered care, and particularly regards to person-centered maternity care. And so one of the key takeaways from this work is the fact that increasing provider preparedness would be critical to ensuring responsive and respectful maternity care, because decreased preparedness leads to stress, which leads to dissatisfaction with the job, fear of infection, all of which leads to lack of respectful and responsive maternity care. The next steps for this project is complete analysis of the survey data. So we just paused the survey yesterday to conduct the analysis, and then we'll move on to the qualitative phase of it, which will be based on the findings of the quantitative data. Fortunately, we got one of the UCSF rapid response grants, and so that would help support the qualitative piece of it. We are in discussions to do a similar survey in Kenya, and we were also awarded a Bixby RAP to look at drivers of poor person-centered maternal health in Ghana. And so this is an opportunity for us to focus on issues specific to maternal health in the context of COVID-19 going forward. So I will pass on to Nadia, and then we can come back to questions later. Thank you.
Great, thanks so much, Patience. All right. Can you all, hopefully you can all see my slides. Oop, can you see them? Maybe I'll do them like this.
Not yet, Nadia.
Not yet. Here we go. Sorry. There we go. Sorry about that. Oop. Can you see them now?
Yes, thank you.
Sorry about that. Thanks, Patience. So moving from the provider to people, to their reproductive and maternal health, I'm going to talk a little bit about some data we've been collecting in India using Facebook ads to look at the gendered impacts of COVID-19 on reproductive health. And I want to acknowledge my collaborators, Lakshmi Gopalakrishnan, who's a UC Berkeley PhD student, and also Upswell, which is an organization that does other work with social media for collecting data, and my colleagues in India, Sumit and Nandita. So in India, like all around the world, or many places around the world, a very strict lockdown started on March 25th. And this was much stricter than what we saw here. You know, people really weren't supposed to leave their house at all. People were being arrested if they were out. There was set times when you were allowed to go to get food. So it was really pretty strict. And soon we started seeing reports of, what impact this might have on many outcomes, including maternal and reproductive health. So this is the Times of India in May asking, is there going to be a baby boom? And in India, and I don't know if you can see this link down here, this clip that's talking about a UN report that was estimating that the extended lockdown might lead to 7 million unwanted pregnancies globally. And then we started seeing other types of information. So this was a post by a online pharmacy delivery service about what type of services they were being requested to send people. So pregnancy kits, family planning methods. So we decided that it would be important to look at this more in detail and wanted to understand the impact of COVID-19, but especially the associated lockdown on maternal and reproductive health care access and use. So this was looking at pregnancy, childbirth, postpartum, family planning, and abortion services. We also collected data on fertility decision-making to see how people were thinking about wanting babies or not wanting babies due to COVID, and then also exposure to violence as a potential pathway if we did see increased in pregnancies, and then also collected data on mental health, economic impacts, views of COVID. And we collected data from both men and women. Men are often left out of surveys, especially in reproductive and maternal health, but they are important decision makers, and especially so in the Indian context. And we thought we wanted to look at changes over time as the pandemic and the lockdown changed. So the design of our study was to collect an online survey, and we initially were thinking of doing this for 4 months and are hoping to do it longer. And we wanted to try to recruit a panel who we would follow monthly for 4 months, but then in case that didn't work, also collect cross-sectional data each month. And we offered a raffle for people for an iPad mini for those who completed the 4 months of the survey. The eligibility was being over 18, but otherwise there was no eligibility criteria. And to collect data, we used Facebook and Instagram ads. And so we sent out surveys embedded in an ad, and I'll show you an example of that in a minute, on April 14th. So again, like patients, we were able to do this really quickly, got very fast IRB approval, programmed the survey into Qualtrics. And so first we sent them out broadly across all of India. And then because after a little bit of time, we weren't getting quite enough women of reproductive age, since those were our main outcomes of interest, we sent out some more targeted ads specifically at women of reproductive age. So how does targeting on Facebook work? Based on the information that people enter when they first make a Facebook account, you can target ads to specific people by age, sex, region of the country, also number of children and marital status. And this information is not actually, when we get the data on people, we can't see this information. So I know that it's a little bit, funny to think about privacy and collecting online data like this, but so if we want to know someone, what their sex or number of children are, they have to tell us that in a survey, but Facebook can feed information to certain types of people. And the idea with Facebook ads is that you design a lot of ads with different images, and you send out ones to certain demographics that might appeal to might be more relevant to certain people. And then when that ad is more successful, so people are looking at it more and clicking on it more, you might send out that ad more to that type of demographic. Ads do cost money, and roughly the estimate is about $3 per completed survey, although I think that this, I was talking to a colleague in Germany this morning who was doing something similar in Europe, and he said that theirs were under $1 per completed survey. And basically the more money you have, the more respondents you can get. So here's an example of the ads that we sent out. So this would appear in someone's Facebook or Instagram feed. People can like it, comment on it, share it. Apparently people commented, made a lot of comments in these. And we can, again, monitor the ads and repost the best ones, the ones that are getting the most number of clicks. So we have done 2 rounds of data collection so far. So again, the lockdown started on March 25th. On April 14th, so just 3 or so weeks after that, we sent out the first round of surveys. And then about a month later, we both followed up with people who gave us their email addresses in our panel. And then we also tried again using Facebook ads to recruit a new sample. So we sent out our new cross-sectional survey. We got some slow responses in the beginning, and I'll show you a table on the next slide. So then we reordered some questions and tried to shorten it a little bit and sent out another push for some more respondents. So that was our total sample of round 2, is the 2 cross-sectional components and then the panel. So I know this table is a little busy, but I wanted to show you guys a little bit in case people might be interested in thinking about this data collection approach, some of our findings. So in our first round, we sent out surveys both in Hindi and English, and we fed this survey to over 4 million people. You can see that about 1.4% of people who were fed it clicked on the ad. And I'm combining the data from English and Hindi in this first row here. And then of those, about 22% of the Hindi ones and 36% of the English ones started the survey, and the completion rate was about 40%. In our second one, you can see we reached a lot more people, but had much lower percent of people who clicked on the ad. And so this was our round 2, which was in May. And then of the people who started the survey, again, a much smaller proportion of people started the survey, but of those who started it, 40% or so completed it. As I said, since we had such low numbers, we tried again. We didn't get much improvement, unfortunately, in terms of the number of people we were recruiting. You can see up here we had about, over 6,000 respondents, in here, barely 1,000. The panel, initially, almost 5,000 people in that first round gave us their email and said that we could contact them again and they wanted to be part of our panel. Only 500 of them responded, started the survey when we sent out the link for round 2, but the vast majority of them did complete it. So even though it was a smaller sample, they were more committed when they did start it. So what are some thoughts on why this happened? Could be technological. The survey was slightly longer the second time. We got really excited and wanted to ask more questions. We also changed the data collection platform. We did it in Typeform the first time and then Qualtrics the second, which maybe led to some kind of issues. It also could be timing related. Maybe, a month later, COVID stopped being as interesting to people, so they just weren't as excited about answering surveys. People had adjusted to the lockdown, didn't have as much time. Also, about the time we were sending out the second survey, the lockdown was projected to end. It didn't end up ending, but it's possible that people were kind of, losing interest in these things overall and ready to move forward, and that had something to do with it. One of the main questions I've been getting is, how do we know anything about these people who are answering surveys on Facebook? So I wanted to show you guys a little bit about our findings compared to all of India. So our sample was a little bit more male, 58% as opposed to 52%, a little bit more heavily weighted towards younger people, which we would expect. And we also did a push for women of reproductive age. And a slightly smaller proportion was married. This is probably because they were younger. I was surprised that we got any rural people in our sample. It was about 36%, but this is much lower than representative of all of India. And we oversampled people in the north of India, but otherwise it was a pretty good distribution of the rest of India. There was a pretty wide swath in terms of the annual income that people reported. The average in India is about $16,000, and we were kind of right around that. Probably if you made an average of what people said, we would be close to that. So looking at the impact on reproductive health care, just in general, 60% of people said that they were facing some barriers to health care. And the main reasons they listed, and this is in order of how frequently people listed them, were not being able to go out because of lockdown, being afraid, not being able to get in touch with the doctor, and less time due to increased childcare and elderly care. And 20% of people said that they had some type of online or voice interaction with their provider since COVID. So it does seem so that there there were quick changes. This is all data from round 1. In terms of those who were either pregnant or had recently delivered, 45% said that they faced some type of barrier, and this was because they were afraid to go to the facility or not able to go out. And I looked specifically just this morning, and about 15% of people said that they were less likely to deliver in a facility because of COVID, 16%, 15% of these 300. 17% of abortion, of those considering abortion said they faced a barrier. And of those who were not pregnant, 32% said that they faced a barrier in family planning access. And again, this was mostly due to not being able to go out because of lockdown, less time, not enough money, and then afraid. 70% of people reported that COVID had impacted their fertility preferences, mostly that they wanted to delay having a baby now. 13% of pregnant women who were under 5 months, which is the cutoff for abortion in India, said that they were considering an abortion because of COVID. And already just 3 weeks in, 3% of non-pregnant people had stopped using their method because of COVID, and this had increased to 6% by round 2. A little bit about some of our other findings. This is just comparing the panel data of round 1 and round 2. You can see a slight increase in some mental health, reports of adverse mental health outcomes. I haven't been able to look at the round 2 data on violence yet, but we were surprised to see that more people reported less violence because of COVID-19, as opposed to more violence, and there weren't huge differences between men and women. And we think this might have something to do with lack of access to alcohol during the initial stages of the pandemic, where people can go outside and buy alcohol. And so maybe since people were at home and there wasn't as much alcohol consumption, they were actually less exposed to violence. And we'll see how this changes over time. And we ask more detailed questions about this in the second round. Some other things that might be of interest. There was an increase in people who said they'd lost their job over time. We did add a category in the second round for this being not applicable, that people weren't working before the pandemic, especially since there's a lot of women might have been working in the home. And so that did change a little bit of our interpretation of the no category. There was an increase in lost income over time. We asked people what their top 3 concerns were, and most of these were related to work or finance, healthcare facilities. There was, discuss about concern for the country. People just talked about depression and loneliness. We ended up having a lot of write-in questions, which has really led to the analysis of this being challenging. There's a lot of Hindi and a lot of feelings and emotions to code, so we're working through that. And we did ask about COVID testing, and there wasn't a huge change between round 1 and round 2. A slight increase in the number who said that they had been tested for COVID, not change in the positive rate over time. So summary, it seems like, for the most part, these Facebook and Instagram ads were successful in recruiting a pretty large and diverse sample at that point in time. It is biased. It seemed a little bit harder to recruit our cohort, our panel, and maybe that recruiting, starting with social media and then moving to email might be challenging, and especially in a setting like India where people use social media more than email. We find that men and women were facing barriers to services just 3 weeks into the lockdown, and we think this is likely to continue over time. And what are our next steps? So we're going to apply some sample weights based on comparison to nationally representative surveys. I think there's a lot to think about, not just how do these people compare to India overall, but how do people who answer Facebook surveys specifically compare to other Facebook users, and how do those people compare to the broader population? And there's some people who are doing research like this in the US and Europe, but doesn't seem like much of this type of research has been done yet in low and middle income countries. We're going to look at trends over time, subpopulations, continue with our targeted follow-up surveys over the next few months, and explore gendered effects on and different pathways in terms of violence and other behaviors on outcomes. Thank you very much. And I'll turn it back over to Jaime, I think.
Yes, thank you, Nadia. Beautiful presentations, both by you and patients, and also Dilys. Very impressive work. I'm sure we have tons of questions. Colin Boyle will be moderating the Q&A. If you have questions, please post them in the Q&A icon. We only have about 12 minutes to go, but hopefully we will be able to answer some of the questions. Colin.
Yes, thank you, Jaime, and thank you to our presenters. Very interesting and a little depressing, kind of consistent with the times. So thank you for that. I think it's an important set of issues. We did have one question, a methodological question, I think, for you, Nadia, which is really around the recruitment. And did you target states that were primarily ones where Hindi is spoken?
No, we didn't. Yeah, as I'm sure many of you know about India, there's a lot of languages. And that's why we wanted to give an English option also, in the hopes that maybe where people didn't predominantly speak Hindi, they might be able to answer the English one. For the follow-up rounds, we just did it in Hindi because we got such a lower response rate for the English one. So no, we didn't target Hindi-speaking states. There was no specific focus geographically.
Okay, thank you. And then a question for patients. Patients, your comments about the impact of the pandemic on healthcare workers, and specifically the impact of stress and preparation is really quite interesting. And I'm wondering if in the course of the work you've been doing, you have any insights into the sorts of things that we at UCSF, or as the Institute for Global Health Sciences, can do to help healthcare workers around the world be better prepared in the form of additional training, resources, or other information. Any thoughts on that and what we might prioritize?
Yeah, so one of the most consistent predictors of preparedness so far has been training. Sorry.
Sure.
Has been training. So training is a very significant predictor of perceived preparedness. But then also it's all the things that are not really surprising. So availability of PPE is the second one, that those who report that their facilities have PPEs are also more likely to feel prepared. We had another question asking them what has been the most frustrating issue for them since the pandemic, and 75% said PPEs. So PPEs seem to be the biggest issue right now. But then also there are issues of lack of clear protocols. So many either think they don't have protocols, or they don't know if there are protocols in their facilities in terms of what to do when you suspect a case, what to do when you confirm a case. So far it's training, this lack of clear protocols, and also availability of PPEs. And the other ones we found was just having an isolation ward. So many also said their facilities have no separate isolation ward for managing COVID-19. The thing I want to note about the issue of isolation ward also is that some facilities have been designated as COVID facilities. And so not every facility necessarily has to admit a patient with confirmed COVID-19. But the period between the transfer and, the period between diagnosis and transfer, there is still the need to have a place where you can have such patients. So for now, I'll say these four things are important to increase in preparedness. But then also just the issue of feeling appreciated by their management for what they are doing, and having clear communication from management is also very important.
Great, thank you very much. One other question for Nadia back on the recruitment side. There was one other question around economic incentives. Were those offered to try to draw people in?
So we did have this raffle for an iPad mini for people who participated in the panel, but we didn't have anything if people just participated once. And so for all the people who just did it once, the second time, they wouldn't have been offered anything. So we definitely think that might have been an issue. And hopefully if we get some funding for this, we are definitely thinking about how to have a small, phone credit incentive for round 3. And we definitely think that that would increase participation.
Great. Okay, and then one question for Dilys, and it's kind of a two-parter. The first, I think people are struck by the statistics and the predictions around the maternal deaths related to COVID, including the ones that are ancillary impacts of the pandemic. And the question is what we can do to make in-home maternity care and home births more safe and yield better outcomes? How would nurses and midwives tie into this? And then the second part of the question is, given the impact this seems to be poised to have on maternal and child health, is there any indication from countries that they're looking to make greater investments downstream into strengthening healthcare capacity around maternal and child neonatal health? Is there any kind of silver lining to the realities of what's happening that would lead to better outcomes in the future by virtue of better resource allocation?
Yeah, thanks, Colin. Good questions. And I think I'll start with the second one. So I recently got back from the first convening of the STAGE group, which is the strategic advisory group to Dr. Tedros at the World Health Organization. So that convened a group of maternal, newborn, nutrition, adolescent specialists from around the world to talk about, how to best advise WHO, at the top leadership on these issues. Now, not surprisingly, COVID came up as the number one issue. When this group was convened 6 months ago, COVID was not on the horizon. And now, like in every space, it's number one on the horizon, but much more on the side of worrying about, is this an opportunity to get greater investment because of the impact of these indirect impacts, which we can model out and probably soon we'll be able to document as people are beginning to document the actual numbers. There's much more concern that those maternal, newborn, family planning resources will be redirected to other areas as these systems are being stressed and needing to create isolation wards and buy PPE and buy testing, that the first to go will be these essential services. So even though I like to think there's a silver lining because the things they need to do to make it better could lead to lasting system changes, it's all dependent on how those systems make those decisions. And in terms of that first question about safe home delivery, many people are thinking about this. It goes absolutely contrary to the Margaret Crook model of get everybody into a hospital where you can deliver by C-section within 30 minutes. That's not the situation. But again, when you think about the forces that are affecting women's decisions about going to a facility and the quality of the services at the facility that are being impacted by this, I believe there probably is an equation whereby you can get in Kenya, there are many retired midwives who do home deliveries. If you were able to effectively link those retired midwives to safe delivery kits and transport to get them to where they need to go in a place that's not crowded, I think there's an equation by which that is a better choice for many people.
Great, thank you, Dilys. Those are the questions. Jaime, why don't I turn it back over to you?
Thank you so much, Colin. I do have one question for patients, if I may. I wonder if you were able to share your results with the hospital or even local authorities. And do you think that would have made a difference in improving the safety of health workers?
Yeah, so those are actually the opportunities we are looking for now to try and share these results back. We haven't had the opportunity. Actually, like I said, we just closed the survey yesterday, and I was able to run this because we have been building the do files earlier on. But now that we've closed the surveys, the thing we are planning to do is share this through presentations at the local level. And we're also beginning to plan short one-page dissemination briefs that we can have shared with people at all levels, including the hospital authorities. So we're hoping to do that. We haven't done that yet.
And Dilys, is this an opportunity to rethink about C-sections in low and middle income countries?
Well, by rethink, I think, there's obviously an opportunity around C-section generally, just because of what is happening around the world with cesarean section rates. And women who undergo cesarean section stay in health facilities a lot longer, so that increases their risk of transmission. And C-section in and of itself is not without risk. So I'm not sure it's about rethinking C-section. I think it's rethinking the whole delivery experience and probably birth. When I think about what is the risk of COVID, my images goes to the postnatal wards where you have 3 and 4 women to a bed. Like that is a fairly simple system problem that if you could just get 1 woman to a bed, you could decrease the rates of transmission of COVID, and you could provide more respectful maternity care. So those are the kind of solutions one would like to see enacted.
Well, I want to thank Nadia, Patience, and Dilys for a really superb presentation on a really important topic. We're ending just in time. Thank you so very much for joining us, and see you next Tuesday. Goodbye, everyone. Thank you.
Thank you.